Sakshi Kahane for our role play.
So, hello everyone. I am your today's narrator for today's drama, The Madness of Crown. What do you think? The crown is mad? No, not actually. Crown is not mad. The person who is holding the crown is considered to be mad. So, this is the case of King George. It is a true story. So, join me as we journey back to the past, where behind the greatest grandeur of the royal courts there lies a hidden struggle. King George was considered a madman because the disease which he was suffering from was not diagnosed at that period of time. It was acute intermittent porphyria, but the doctors who were treating him considered this condition as, because since there were some neurological disorders, so they considered it as a madness. So let me introduce you with the cast firstly. Introducing Samiksha Dange as King George. Rudri Bhagat as King George's mother, Sakshi Yadav as Queen Charlotte, wife of King George, Rishikesh and Rishikesh as ministers, and Sakshi Dane as Dr. Willis. So,
मैं एक महान राष्ट्र के सुख दुख और पीड़ा के लिए जन्मा हूँ और इसीलिए मुझे अपनी इच्छाओं के विपरीत कार्य करना पड़ेगा.
young George was the greatest ruler of that time. He was the ruler of greatest nation, the Great Britain. But he was suffering with the disorders, and this was not known when he was young. So at that time, he took over the responsibilities of the kingdom, and lot of responsibilities were with him. But among all these greatest tasks which he was doing, one of the major tasks was finding a queen. Because at that time marriages, the royal marriages were not supposed to be for the love purpose. It was for the future of the monarchy. The queen should be a confident person who will help and guide the king with the right option. So we will now witness the scene where King George's mother is addressing her son, showing the obstacles in the royal marriages and guiding her son through the obstacles.
जंग ने खजाने खाली कर दिए और अमेरिका की कॉलोनी में हमारे से कौन टैक्सेस बंद करने की धमकी देती है और पार्लियामेंट में बगावत है. जनता को राजा की जरूरत है. हम जानते हैं कि तुम्हारे जीवन में बहुत सी मुश्किलें हैं, पर उन मुश्किलों को सुलझाने का हमारे पास समय नहीं है. इसलिए हमने तुम्हारे लिए नानी ढूंढी है, सोफिया शाह.
As we witnessed, the queen was asking about the marriage and king was responding something else. So by this time, queen understood that there was something wrong with her son, something physically or something mentally. So she decided to treat her son. So she approached the major doctors, greatest doctors of the era, and the same thing she got in the response. The king is mad. He is neurologically ill. He has a psychotic disorder. All the kings claim this is the king is mad because nobody could identify what was the actual diagnosis. So she finally decided Dr. Willis as a person who would treat the person in the better way, because Dr. Willis was not a person who considered the patients who has neurological disorder as a madman. He understood them as a person who is suffering with something. So we will witness the scene between Dr. Willis and the King George. the obstacles and the disorders which king was going through, king finally married Queen Charlotte. But Queen Charlotte, at the time of marriage, she didn't know that king is suffering with something. So when she realized that king has some kind of disorder, then she was devastated and shattered. So she went to the king's mother to share her misery. But this conversation was overheard by the king, and king was heartbroken by what he listened to them.
राजा पागल नहीं है, वो बस इस दुनिया के महान देश को संभालते संभालते थक गए। तुम्हें उन्हें टूटने से बचाना। तुम एक ऊंचे तट पर बैठे हो, उनकी कमियां तुम्हें छुपानी पड़ेगी। ये तुम्हारा कर्तव्य है।
कुछ कमियां वो आसमानों से बातें करती हैं, मुझे तट पे नहीं बैठना, मैं आपके साथ नहीं।
मैं पागल हूँ, मैं खतरनाक हूँ। मेरे दिमाग में कई सी दुनिया बसी हुई है, और उस दुनिया में धरती और आसमान एक है।
मैं तुम्हारा साथ दूंगी, मैं उस धरती और आसमान के बीच बात करने को दूंगी, तुम हिम्मत ना हारो।
She was the queen of the greatest nation, so she knew how to handle her husband. So she decided to help the king with the disorders he was suffering through, and this issue that king is having some disorders and he is not well mentally. This was to be kept secret from the public. But one day, when the king was rushing, something unexpected happened.
आपको मालूम है इसलिए लोगों को आपकी जरूरत है।
हाँ, हम जरूर मिलेंगे, और हाँ, हमें पार्लियामेंट में एक शानदार भाषण देना होगा, ताकि लोगों को ये ना लगे कि मैं एक पागल राजा हूँ, बल्कि उनको गर्व होना चाहिए कि मैं उनके लिए एक प्रभावशाली राजा हूँ।
This was the time when king was present in the parliament. So this whatever is happening, this is in front of all the people who were present in the parliament and all the people of the nation who were there when the king was going to address them. So this problem which king was suffering to was exposed publicly. So now everybody came to know and understood that king is having disorders. And since the doctor couldn't diagnose the disease, and it was the claim that king is mad. So now, as we know, the king wasn't mad. He was suffering through a disease called acute intermittent porphyria. That is the reason why he had some neurological disorders and abdominal pains, as we have seen in the play. So now I will take you through a factory where the normal pathway of the heme synthesis takes place, and we will also see what was the defect in the heme system that led to this kind of disorders and the acute intermittent porphyria. So I will now hand over the narration to Sakshika.
Biosynthesis of heme. Site is the all living cells, mainly nephroid precursor cells present in bone marrow and in hepatocyte. Then precursor, glycine amino acid and succinyl CoA, which is intermediate in breast cycle. Hematopoietic vitamins, that is vitamin B6 and vitamin C. Steps of heme synthesis occur in mitochondria and cytoplasm. Biosynthesis of heme occur in following stages: formation of their aminohydrogenate, synthesis of porphyrias, formation of porphyrin rings, conversion of leucoporphyrinogen 3 to porphyrin 9, synthesis of heme from protoporphyrin 9. Now, let's demonstrate the heme biosynthesis pathway. glycine. Glycine and succinyl-CoA in the presence of ALH synthesis and PLP is converted into del-aminoleucine. This is the rate determining step in heme biosynthesis, and this is also inhibited by it. Then two molecules of del-aminoleucine condense and in the presence of ALA dehydratase and form protoporphyrinogen. This ALA dehydratase is a zinc containing enzyme and is inhibited by, and it is a very sensitive, so inhibited by heavy metals such as lead. Now 4 molecules of PBG is in the presence of uroporphyrinogen 1 synthase and removal of ammonia, it is converted into hydroxymethyl. It is a linear tetrapyrrole, and the linear tetrapyrrole in the presence of uroporphyrinogen 3 co-synthase is converted into uroporphyrinogen 3. In the presence of uroporphyrinogen, decarboxylase and removal of CO2 form the coproporphyrinogen 3. Coproporphyrinogen 3 in the presence of coproporphyrinogen oxidase is converted into protoporphyrinogen 3. The difference between coproporphyrinogen 3 and protoporphyrinogen 3 is here is the propionyl, here and here is the propionyl is converted into vinyl. And protoporphyrinogen 3 in the presence of protoporphyrinogen oxidase is converted into protoporphyrinogen 3 or 9. Protoporphyrinogen 9 in the presence of protoporphyrinogen oxidase is converted into protoporphyrin 9. And the protoporphyrin 3 in the presence of ferrochelate heme synthase, it is a mains and addition of iron is converted into heme. And this step is also inhibited by lead. First step is the rate determining step. These steps occur in mitochondria and this occur in cytoplasm. Now the regulation of synthesis of heme. Heme production in liver, mainly in liver and erythroid cells. Erythroid cells due to the formation of hemoglobin and in hematocyte formation of hemoproteins such as the cytochrome P450. It is the involved in detoxification and two different mechanisms in regulation of the regulation in liver. The first step, that is the glycine and succinyl-CoA in the presence of del-amino ALA synthase is converted into del-aminoleucine. This step is a rate determinant step and also it is inhibited by the heme or oxidized state of heme, that is the hemine or hematite. And this is controlled by 3 mechanisms: feedback mechanism, repression of ALA synthase, inhibition of transport of ALA synthase from cytosol to mitochondria. Effects of drug on ALA synthase is increase the activity of ALA synthase by the addition of these drugs, phenobarbital and insecticidal and carcinogens. Regulation of erythroid cells. There is the del-aminoleucine ALA synthase is not regulatory enzyme in erythroid cells. Erythroid cells is in the uroporphyrinogen synthase and ferrochelatase. That is the last steps. This is the regulatory information enzymes. Uptake of iron is also influences synthesis. Now let's discuss about the acute intermediate porphyrias. This is the genetic disorder, that is the autosomal dominant disorder, and in this that is the uroporphyrinogen 1 synthase is a deficiency of uroporphyrinogen 1 synthase. Deficiency of this enzyme occurs to the accumulation of alpha del-aminoleucinic acid and porphyrinologen. And urine is darker due to the exposure of air because of protoporphyrin porphyrin is converted into protoporphyrin and porphyrin.
As we have seen acute intermittent porphyria in the rule play, let us see other types of porphyrias. On the basis of clinical classification, porphyrias are classified as acute and chronic. The acute types are acute intermittent porphyria, hereditary coproporphyria, and variegate porphyria. And cutaneous porphyrias are erythropoietic protoporphyria, porphyria cutanea tarda, and congenital erythropoietic porphyria. As already discussed, in acute porphyria, there are neurological symptoms, whereas in cutaneous porphyrias, there are various skin-related problems. Porphyria cutanea tarda, it is also known as cutaneous hepatic porphyria, and it is most common type of porphyria. In this, mostly liver is affected. It may occur due to overconsumption of alcohol or iron overload, and in this, deficiency of enzyme uroporphyrinogen decarboxylase occurs. Excretion of uroporphyrins 1 and 3 occurs, and rarely porphobilinogen. Cutaneous photosensitivity, as it is a type of cutaneous porphyria, and liver exhibits fluorescence due to high concentration of porphyrins. As we can see in this image, these are the blisters present and hypopigmentation is present in the hands of the patient. Moving toward the other type of porphyria, it is congenital erythropoietic porphyria. It is also known as Gunther's disease, and it is caused by the elevation of both water-soluble and lipid-soluble porphyrins due to the deficiency of enzyme uroporphyrinogen 3 co-synthase. It is a rare congenital disease, and it is an autosomal recessive disease, whereas the acute intermittent porphyria was autosomal dominant disease. And the patients are photosensitive due to abnormal porphyrins. Individuals excrete uroporphyrinogen 1 and coproporphyrinogen 1, which oxidizes itself into uroporphyrin 1 and coproporphyrin 1. In this image, we can see lots of scars are present on the face of the patients, hypopigmentations are present on the upper and lower limb, and loosening of the tissues from the regions which are overexposed. Now we are going to see the symptoms of the diseases. In acute types, we have acute intermittent porphyria, and the symptoms include abdominal symptoms like abdominal pain, vomiting, and cardiovascular abnormalities. In neuropsychiatric disturbance, that is caused by the reduced activity of tryptophan pyruvase due to the depleted HeLa, and the accumulation of tryptophan and 5-hydroxytryptophan. There are also drug inducibility like barbiturates. So in barbiturates and similar drugs, it induces cytochrome P450 synthesis, and that leads to the increased ALE synthase activity and the accumulation of PPG and ALE. And it also causes photosensitivity. It doesn't cause photosensitivity. The patients are not photosensitive. What is photosensitivity? That is sensitive to the UV light which is present in the skin. And the enzyme effect occurs before uroporphyrinogen formation. In porphyria cutanea tarda, here the photosensitivity occurs. There is increased excretion of uroporphyrins 1 and 3, and rarely porphobilinogen. So there is cutaneous photosensitivity, and it is the most clinical important manifestation of these diseases. And the liver exhibits fluorescence due to high concentration of accumulated porphyrins. In congenital erythropoietic porphyria, the level of type 1 porphyrin increases in the blood, which is leading to photosensitivity. So in acute intermittent porphyria, there was no photosensitivity. In the other two diseases, there is photosensitivity. There is an excretion in the urine of type 1 porphyrin, which means it's look like red color or porphyrin color, as you can see in the image. And the major manifestation relate to the skin due to the photosensitization by the presence of porphyrins in the capillars.
Diagnosis and lab findings. Diagnosis of porphyrias may be sometimes confused with the lead poisoning and type 1 tyrosine. So there are some tests which are confirmatory that the disease is acute porphyria. PVG. Along with this, porphyrinogen may also be accumulated in acute intermittent porphyria. It is in the normal level. Watson-Shedworth test. Watson-Shedworth test is a test which is at the screening of porphyria. What are porphyrias? Those we already learned that they are the metabolic disorders which affects the hemoglobin metabolism. Method is Ehrlich's reagent. What Ehrlich's reagent contains? It contains para-dimethyl aminobenzaldehyde and hydrochloric acid. So procedure is like 1 ml of urine is added in 5 ml of water and 7.5 ml of DMAD. And now it gives, if the color it turns into red, we will say that the test is positive. And now we are wondering what is the action of this and what is the action of hydrochloric acid. So dimethyl aminobenzaldehyde combines with PPG, that is porphyrin to convert into the red colored complex. Thus if PPG is present, red color will be developing. And now we will be wondering that why hydrochloric acid is added when there are some disorders to the people, the patients, their urine might become acidic, and acidic urine sometimes contains methyl, red and urocin, these like compounds. So they will also give a red color with this DMAD. So to nullify those effects, hydrochloric acid is added. Now if we have to confirm the test, we cannot rely on the one product which we get. So for confirmation, we will add chloroform in the solution, which red color, which we already got if PPG is present. So if in the aqueous phase red color is persistent, and when we are adding the organic solvent, which is chloroform, if that solution turns into pink, then we will confirm that there is a presence of PPG. So clinical relevance of this test is Watson-Shedworth test. In the individuals which is having abdominal pain and neurological disorders and photosensitivity, it will be the confirmation that those patients can go into the further investigation into porphyrias and quantitative measurements of PPG. Limitation of this test is screening of this test is not definitive diagnosis. So for definitive diagnosis, we will use anion exchange resins for confirmation. And alternative test for this is Hosing's test. Now a further explanation will be done by Sanch.
So let's continue. Some other diagnostic features for detection of various porphyrias. So first of all, PBD, that is porphyrin, which is a highly indicative for acute intermittent porphyria, a type of acute porphyria. And urine color also, such as elevated porphyrins, will cause the urine for fluorescence, and we would be given the reddish urine color, which is also a detection feature. Further testings can be porphyrin fractionation, plasma fluorescence emission. Fecal porphyrin labels can also be used in distinguishing various types of porphyria, such as delicate porphyria, hereditary coproporphyria. Now, further case studies for porphyrias will be given by Rajendra.
So, good morning everyone. There are two cases on porphyrias. One will explain by me, it's Rustes Radharik, and next case will be explained by my brother Rustes Rao. Case number 1. Sanskruti, a 16-year-old girl, was came to OPD with the symptoms of abdominal pain, confusion, signs of no fever. The doctor did the urine test and there was a brown discoloration of urine. Low magnesium levels were also found. So now, what is the probable diagnosis? So probable diagnosis of this case is as there are the symptoms of abdominal pain, then neuropsychiatric means confusions and other symptoms like dark color urine. Dark color urine is generally due to the presence of porphyrogen in the urine. This porphyrogen, when urine is kept in the air, this porphyrogen is converted to porphyrin and porphyrin. So the diagnosis of this case is acute intermediate porphyria. Next question, the neurocytotic disturbances observed in the patient is due to the reduced enzymatic activity of which enzyme? So the neurocytotic disturbances observed in the patient is due to the reduced enzymatic activity of tryptophan pyruvate, which is caused due to the depletion heme levels. This enzyme helps in detoxification of tryptophan, which leads the tryptophan and 5-hydroxy tryptamine to accumulate. This is caused due to which enzyme deficiency? This condition is caused due to deficiency of enzyme uroporphyrogen 1 synthase. Now generally what happens? Porphyrogen is converted to uroporphyrogen presence of enzyme uroporphyrogen 1 synthase. But in this acute intermediate porphyria there is deficiency of uroporphyrogen 1 synthase. So due to this step is inhibited, and due to this accumulation of porphyrogen leads to acute intermediate porphyria. Next, how is AIP treated? What are the effects if the drugs are administered? The AIP is treated by administration of imetin, which inhibits the enzyme ALA synthase and accumulation of porphyropilogen. Now, these drugs are administered, then symptoms are more severe. For example, barbiturates. When these drugs are administered, the symptoms increases and are administered, it induces the synthesis of cytochrome P450. This is due to the increased activity of ALS synthase and causing accumulation of PBG and ALA, porphyrogen and alpha-ketoglucoline.
Case 22, patient is 25-year-old man and he has blister on his skin. When he exposed to sunlight, he experienced pain on his skin. So आपण त्याच्या युरिन टेस्ट केलं तर आपल्याला हे कळलं की त्याच्यामध्ये porphyrin 1 and 3 ची लेवल इन्क्रीज झालेली आहे आणि तो एक क्रोनिक अल्कोहोल कंझ्युमर आहे. सो आपण त्याचा डायग्नोसिस बघूया. सो आपण अगोदरचे सिम्पटम्स आणि त्याच्यात आपली रिपोर्टनुसार आपल्याला हे कळलं की याला पॉर्फायरिया क्युटेनियम आर्डा डिसीज झालेला आहे. सो त्याच्या इथं काही 1-2 इमेजेस आहे. याच्यावर क्रिस्टल्स आहे स्किनवर. कोणत्या एन्झाईममुळे याची डिफिशियन्सी होती तर एन्झाईमचं नेम आहे porphyrogen कार्बोक्सिलेज. तर याच्यामुळे होतं काय की जर डिफिशियन्सी असेल तर porphyrinचं ॲक्युम्युलेशन होतं की बॉडीमध्ये आणि पर्टिक्युलरली स्किनमध्ये आणि युरिनमध्ये ॲक्युम्युलेशन होत असतं. सो ॲक्युम्युलेशनमुळं याचं काय होईल की स्किन सेन्सिटिव्ह बनल, अजून फ्रेजाईल बनल, अजून याच्या स्किनचा कलर चेंज होईल. नेक्स्ट
acute and chronic. Coming to the biosynthesis of tea, the precursor is glycine and succinyl CoA, and the pneumocoating vitamins vitamin B6 and vitamin C. And the site is erythroid precursor cells in the bone marrow, hepatocyte, except mature RBC as it does not contain mitochondria. And coming to the diagnosis, there is increased plasma and urinary ALA. ALA is delta amyloglobulin, urine color, which is porphyrin and congenital erythropoietic porphyria, and the Watson-Watts test, which is positive for neurological disorder, abdominal pain, and the lead causing. In lead causing, the ALA dehydratase enzyme contains zinc. In the presence of lead, the lead will displace the zinc and the enzyme gets inhibited, into which the ALA will increase. And coming to fecal porphyrin, the fecal porphyrin is used to differentiate between different types of porphyria, especially the hereditary coproporphyria and the pericytic. Let's compare the three types of porphyria, that is acute intermittent porphyria, porphyria cutanea tara, and congenital porphyria. So the UPG1 synthase. In acute intermittent porphyria, there is deficiency of UPG1 synthase. In porphyria cutanea tara, UPG-B carboxylase, and in congenital erythropoietic porphyria, UPG-3 glucosidase. The acute intermittent and the porphyria cutanea tara are autosomal dominant, and the congenital one is autosomal recessive. There is no color of urine in the acute intermittent porphyria, whereas in ECT and CEP, the uroporphyrin the urine is colored, and in CEP there is porphyrin appearance. The acute intermittent porphyria is the most common one, and the porphyria cutanea tara is the second most common. There is photosensitivity in the porphyria cutanea tara and CEP, and there is no photosensitivity in KM. So let me give you guys some mnemonics of heme biosynthesis. So Sachin and Gautam are PUBG undercover players here. So S succinyl CoA, A succinyl CoA and glycine. U gives delta amyloglobulin. P stands for porphobilinogen. U uroporphyrogen. C coproporphyrogen. P protoporphyrogen. And the last the hero K. Coming to the disorders, there is pneumonitis of double A, tryptophan, very easy. So double A, the first A stands for the delta ALA dehydratase deficiency. The second A stands for acute intermittent porphyria. First C stands for congenital erythropoietic porphyria. Second C for porphyria cutanea tara. The third C for hereditary coproporphyria. P for pericytic porphyria, and E for erythropoietic protoporphyria. So let me first explain you guys this picture. We can see some intermittent light fairies. There are three men. Their nicknames are Bill. The first one is critical alcohol water. It is suffering from acute abdominal pain. The second one is starving because of hunger. And these three are very poor. And these three are hallucinating something. And they are seeing Aladdin in their hallucination. And our second fictional character is the He-Man. UPG D carboxylase, hepatitis C, which is a common virus that causes porphyria tarda, and hyperpigmentation, and uroporphyrin during birth.
Yes, any questions?